Welcome back to the Deep Dive. We have a stack of research on the table today that is, honestly, it's heavy.
It really is.
And I don't just mean the density of the medical text. I mean the sheer weight of this topic. We are looking at chronic pelvic pain. And to start, I want to throw a number at you from this Cancer review that just, it stopped me in my tracks.
I know the one you're talking about.
They estimate that chronic pelvic pain affects 26% of the female population worldwide.
It's staggering. I mean, just think about that. That's roughly 1 in 4 women.
1 in 4. That feels incredibly high for something we don't talk about constantly.
It's massive. And to put that in context for you, that's a higher prevalence than asthma. It's higher than migraines.
Wow.
But if you look at the medical infrastructure for asthma versus for pelvic pain, I mean, the gap is kind of embarrassing. We have asthma clinics everywhere. We do not have pelvic pain clinics everywhere.
And the cost is huge too,
Well,
right?
yeah.
The notes mention billions of dollars a year in the U.S. But here's the real conflict, and this is the mission of our deep dive today. You have this pain that accounts for 40% of all laparoscopies and 12% of hysterectomies. A lot of surgery.
Yeah.
But the research says in 80% of these patients, the pain isn't actually gynecologic.
And that's the paradox. That's what we're unpacking. Pain in the pelvis. Logic says, go to a gynecologist. You assume it's the uterus, the ovaries.
Of course.
Patients assume it, and frankly, a lot of doctors do too. But the data tells us that most of the time, the root cause is not in those reproductive organs.
Which leads to this cycle of treating organ problems that aren't there, or at least aren't the main issue. So today we're unpacking 3 sources to see what's really going on.
We have that big medical review from CanSIG, a deep dive into endometriosis to clarify what that actually is, and then a really fascinating NIH study on postpartum pain.
Right. And we're trying to answer a few questions. Why is this so hard to pin down? How do your organs actually talk to each other to make it worse? And why is the so-called gold standard for diagnosis finally starting to shift?
Let's get into it.
Okay, segment 1, the biological pinball machine. I call it that because the sources describe this bouncing effect of pain. But first, how do we even define chronic pelvic pain, CPP?
Well, the classic definition is pretty simple. Pain in the pelvis that lasts for more than 6 months. But the CanSIG review adds a really critical piece here.
What's that?
That 6-month rule isn't a hard wall. If a doctor sees evidence of what's called central sensitization, basically where the brain's processing of pain is impaired, they don't have to wait 6 months to diagnose.
Okay, central sensitization. We're definitely coming back to that because that sounds like the brain is involved. But first, this evil twin syndrome you see in the reading, it's like these conditions hunt in packs.
They almost never travel alone, and this is why patients often feel so confused. They don't just have one clear symptom. The data shows 48% of women with bladder pain syndrome also have endometriosis.
Almost half.
And it gets even messier with the gut. Somewhere between 30 and 75% of people with bladder pain also have irritable bowel syndrome, IBS.
So wait a minute. You could have your bladder, your bowel, and your uterus all firing off pain signals at the same time?
Yes, exactly. And it's not a coincidence. It's not just bad luck. It's a physiological mechanism called ouchum. And it's a mouthful. Viscero cross-sensitization.
Okay, yeah, you're right. That's a mouthful. Break that down for us.
Think of the pelvis like a really crowded apartment building with paper-thin walls. The viscera, your organs like the uterus, bladder, bowel, they're the tenants.
Okay.
The problem is they all share the same electrical wiring, the same neural pathways that send signals up to the spinal cord. They're on a party line.
Ah, okay, so if one is screaming.
Exactly. If the uterus is screaming because of, say, really bad cramps, that signal floods the whole shared pathway. The bladder and the bowel hear this screaming, and eventually their own nerves become hypersensitive.
So now the bladder starts acting like it's in pain, even if there's nothing actually wrong with the bladder itself.
Precisely. The brain gets a fire call from the apartment building, but it can't tell which apartment is actually burning. It just knows the whole neighborhood is in distress.
Which explains why someone can have surgery for endo. The surgeon says, we got it all, but they still hurt.
Because the neighbors are still panicked, the neural pathways, the alarm system, it's all still ringing. And we haven't even talked about the other huge player in the neighborhood.
The muscles.
The muscles. This stat, honestly, this is the one. 50 to 90% of women with chronic pelvic pain have pain coming from musculoskeletal structures.
50 to 90. So basically, almost everyone. How is that possible? Why do my muscles hurt if my uterus is the problem?
It's a protective reflex. I mean, think about it. If I was about to punch you in the stomach, what would you do?
I'd clench up, Flinch.
You'd guard. Now imagine your organs are hurting you from the inside every single day for years. Your pelvic floor muscles, that hammock holding everything up, they go into a state of chronic guarding.
So they get stuck.
They get stuck. They become hypertonic. They literally lose the ability to relax, and you end up with these knots, these trigger points that generate their own pain.
So even if you fix the organ, you're left with this permanent muscle cramp.
And here's the tragedy. A standard GYN exam looks at the organs. It checks for cysts, fibroids. Unless the doctor is specifically trained to check the muscles, and many aren't, they will miss that 50 to 90% of the puzzle completely.
Which is why so many women hear the phrase, everything looks normal.
The everything looks normal trap. The organs look fine, but the structure holding them is in crisis.
Speaking of things that are hard to find, let's move to segment 2. The big one. Endometriosis. The source calls it the great masquerader. And I think most people know the word, but the deep dive clarified something I definitely had wrong. I thought it was just the uterus lining growing outside the uterus.
That's the common idea, but it's not quite right. It's tissue that's similar to the uterine lining, not identical. And it can grow anywhere, ovaries, bowel, bladder. In really rare cases, they found it in the lungs or the brain.
And it creates these cysts with a very specific and kind of gross nickname.
Chocolate cysts.
Yeah. Explain that one. It sounds deceptively pleasant.
It's not. The medical term is endometriomas. Because this tissue acts like the uterine lining, it bleeds when you have your period. But that blood has nowhere to go. It gets trapped. And over time, that old blood turns dark brown and thick.
Hence, chocolate cyst. Okay, that visual is effective. But the real issue here is how long it takes to find it. The source mentions a diagnostic gap of 5 to 12 years.
A decade of life lost to pain. It's unacceptable.
Why? Why does it take so long? Is it that hard to see?
It's a perfect storm. First, there's normalization. We tell young women periods are supposed to hurt, so when a girl is vomiting from pain, she's told that's just being a woman.
Right. Suck it up.
Second, standard ultrasounds can miss it. You can have widespread superficial disease that's totally invisible on a scan, unless there's a big cyst.
So you can have a clear ultrasound and still be full of it.
Absolutely. And the third factor was the gold standard for diagnosis. For decades, the only way to get an official diagnosis was through surgery, a laparoscopy.
You have to be cut open just to get a name for your pain? That seems so extreme.
It is. And that's why the delay exists. Doctors are hesitant to operate. But the CANSID review, it's highlighting a huge shift in the guidelines. They're basically saying, stop waiting.
What's the new way then?
If a patient has the classic symptoms, the cyclical pain, the bowel issues, and the ultrasound is normal, you don't wait for surgery, you start treatment. Hormonal suppression, pain management, you don't let them suffer for another 5 years.
Especially since, like we said, 40% of those surgeries find nothing anyway.
Exactly. And every surgery creates scar tissue, adhesions, which can cause more pain down the road.
So where does this even come from? I've heard the term retrograde menstruation.
That's Sampson's theory from the 1920s. The idea that some period blood flows backward through the fallopian tubes and plants tissue in the pelvis.
It makes mechanical sense.
It does, but there's a huge hole in the theory. We now know that 90% of women have some retrograde flow. It's normal. But only 10% get endometriosis.
So the backflow is common, the disease isn't.
Right. So the real question is, why does one woman's immune system clean it up and another's lets it plant and grow? And the sources are pointing heavily to genetics. About half the risk is heritable and some kind of immune dysfunction.
And when it comes to getting rid of it surgically, there's this debate, excision versus ablation.
Oh yeah, this is a hot topic. Ablation is burning the surface. Excision is cutting the disease out completely by the root.
Like a weed.
Exactly. And the evidence really supports excision, especially for deep disease. If you just burn the top, you leave the active disease behind.
And we have to touch on fertility. It's a major cause of infertility.
It is, but the source had a really interesting point for older patients trying to conceive. They're now recommending IVF over surgery.
Why is that?
Because every time you operate on an ovary, you damage some healthy tissue. You lower the ovarian reserve, the number of eggs you have left. So the logic is, secure the pregnancy first with IVF, rather than risking the eggs to fix the pain.
Wow, that is a brutal trade-off. Keep the pain so you can have the baby.
It's an incredibly difficult landscape for patients.
And this all connects to the next piece. We've done the organs, the muscles, the wiring. Now, the command center, segment 3, the brain.
Right back to that central sensitization concept.
I want to be really clear on this. Is this just another way of saying it's all in your head?
No. Absolutely not. And that distinction is vital. All in your head implies you're making it up. Central sensitization means the physical structure and chemistry of your nervous system has changed.
Okay.
Imagine a volume knob on a stereo. Normally it goes up when you're hurt and down when you heal. With chronic pain, that knob gets rusted stuck at maximum volume.
So even a small signal, like a full bladder, just blasts through the speakers as agony.
Correct. The brain literally loses its ability to inhibit pain. It creates a state of wind-up. And that's why you see these women start getting migraines or fibromyalgia. The whole system's alarm is broken.
The source material gets into something very sensitive here. The trauma link. The biopsychosocial side of it.
It does. The review notes that women with chronic pelvic pain are significantly more likely to report a history of childhood physical or sexual abuse.
That feels like a statistic that could be easily mishandled. It sounds like you're blaming the victim.
And we have to be so careful. It does not mean the trauma is the pain. It means the trauma primed the nervous system. If you have a history of trauma, your body's threat detection system is already on high alert.
It's hypervigilant.
Exactly. So when pain arises in a vulnerable place like the pelvis, the brain reacts with a nuclear response. It's a biological consequence of a psychological history.
Which makes the standard pelvic exam a potential nightmare.
It can be re-traumatizing. Being told to relax and spread your legs, that can trigger a fight or flight response, which tightens the muscles, which makes the exam hurt even more. It's a vicious cycle.
So the source lists some trauma-informed care recommendations. What does that look like?
It's all about restoring control to the patient. It's asking, is it okay if I touch you now? It's letting them stay dressed during the history-taking part, offering a mirror so they can see what's happening, and never using command language. You can't command a muscle to relax.
It sounds so basic. Treating a person like a partner in their own care.
It is, but for patients who've been dismissed for years, it's revolutionary.
I want to pivot now to a specific group that often gets blindsided by this. Segment 4, the postpartum surprise. This is from that NIH study on Dyspareunia, painful sex in first-time moms.
Right, and they looked at 6 months postpartum, a point where we kind of expect things to be back to normal.
But they're not. The data says that over 20%, 1 in 5 women, reported painful sex as a medium or big problem at 6 months.
It's a huge number.
And the biggest risk factor. This just blew my mind. It wasn't how big the baby was, it wasn't tearing, it was breastfeeding.
The breastfeeding paradox. We push it so hard for the baby, which is great, but for the mother, the study found nearly a third, 31.5% of breastfeeding women reported painful sex. Compare that to just under 13% of non-breastfeeding women.
That's an enormous difference. Why? Why does feeding a baby with your breasts affect your pelvis?
Hormones. When you breastfeed, your body suppresses estrogen. You're in a low estrogen state called hypoestrogenism. It chemically mimics menopause.
Oh, you're essentially menopausal while you're nursing.
Yes, and low estrogen causes the vaginal tissues to become thin, dry, and fragile. Biologically, the body's saying, we're raising an infant, we don't need to reproduce again right now. So it shuts down the resources for sexual comfort.
Wow. Nature is ruthless.
It's a very distinct mechanism, and women are so rarely warned about it.
There was another finding in that study that the authors themselves called puzzling. The marriage stat.
Oh, yeah. This was interesting. Married women were more likely to report painful sex than unmarried women.
That seems completely backwards. You'd think a stable, supportive relationship would help.
You would. The study doesn't say why, but you can speculate. Maybe it's about frequency. Married couples trying to resume intimacy sooner or more often. Or maybe there's more pressure, internal or external, to get back to normal for the sake of the relationship.
That really shines a light on the social pressure to just bounce back.
It really does.
And what about delivery method? I think there's a belief that a C-section saves your pelvic floor.
The data doesn't really support that. In this study, there was no significant difference in pain rates between a spontaneous vaginal delivery and a C-section.
Really? So the surgery doesn't protect you from the pain?
Not necessarily. I mean, pregnancy itself is 9 months of pressure on those structures, and a C-section is major abdominal surgery. They did find, though, that an instrumental delivery using a vacuum or forceps did increase the risk.
It just brings us back to that central theme. It's never just one thing.
It is never just one thing. And that's really the big synthesis here.
So let's wrap this up. If we're moving away from the old way, which was just find a lesion, cut it out, what is the new way?
The new way, as the CanSIG review calls it, is multimodal therapy.
Meaning?
Meaning you need a team. You can't just have a gynecologist. You need the GYN for the hormones and surgery. You need a pelvic floor physiotherapist that's non-negotiable for the muscles. You need a pain management specialist for the central sensitization. And often you need a psychologist to help downregulate that nervous system alarm.
It sounds like a lot for a patient to have to coordinate.
It is. It's a burden. But the old way of just doing surgery after surgery, it just doesn't work for chronic pain. The new way respects the complexity of the biology.
And it tells the patient that the evil twin syndrome, the bladder, the bowel, the uterus, it's real. It's not in their head.
It's physiological crosstalk. It's real.
I want to leave our listener with a thought that really stuck with me from the endometriosis source. We know that half the risk for endo is genetic. We know the immune system is involved, the brain is involved.
And yet,
so many of our main treatments, like using high-dose hormones to create a pseudo-pregnancy, those are concepts from the 1950s.
That's the provocative question, isn't it?
We're using mid-20th century tools to treat what we now know is a 21st century disease.
If we know it involves genetics and the immune system, why are we still just manipulating the menstrual cycle? And why on earth is the average diagnosis time still a decade?
Really makes you wonder how we prioritize women's pain.
It certainly does. There's a lot of work to do.
Well, on that note, we hope this deep dive gave you some clarity. It's complicated, it's interconnected, and it is definitely real. Thanks for listening.
Thank you.